Optimal order of therapies and NET treatment sequencing will be discussed. Hello, this evidence-based content is prepared by Saboor Khan, fellowship-trained consultant surgeon. And if you or someone you care about has been diagnosed with a neuroendocrine tumor and you're trying to understand which treatments to take and when, you're in the right place. I know the phrase, "there's no head-to-head data," can feel like you're navigating without a map, but today we're going to cut through that uncertainty. By the end of this video, you'll understand the proven first-line approach with SSAs, somatostatin analogues, when targeted therapies like Everolimus or Sunitinib make sense, the critical decision about PRRT peptide receptor radionuclide therapy timing, where chemotherapy fits, and how liver-directed treatments integrate into your overall plan. Most importantly, you'll know exactly how to personalize this sequence to your individual situation. Before we dive deeper, let's establish what we're dealing with. Treatment sequencing for NETs, neuroendocrine tumors, means choosing not just which therapy, but in what order. Think of it like planning a chess game rather than playing checkers. The challenge is that unlike many cancers, we don't have large studies comparing treatment A directly against treatment B in sequence. What we do have is solid evidence for individual treatments, combined with expert consensus on how to string them together. For most patients with well-differentiated neuroendocrine tumors that test positive on somatostatin receptor imaging, somatostatin analogues, either octreotide LAR at 30 mg monthly or lanreotide at 120 mg monthly, represent the standard first-line approach. SSAs, or somatostatin analogues, include medications like octreotide LAR and lanreotide. The evidence comes from two major trials, PROMID and CLARINET, which showed these medications don't just control hormonal symptoms like flushing and diarrhea, but also slow tumor growth. In CLARINET, for example, lanreotide extended the time before tumor progression to over 32 months compared to 18 months with placebo. That's nearly doubling the progression-free interval. These drugs work by blocking receptors on tumor cells, essentially putting a brake on growth. They're generally well tolerated. Most patients experience mainly gastrointestinal side effects, like mild diarrhea or abdominal cramping that improve over time. Some develop gallstones or pancreatic insufficiency, requiring enzyme replacement. The key point, if your tumor is Ki-67 below 10% and somatostatin receptor positive, somatostatin analogues give you disease control with minimal impact on daily life. Somatostatin analogues work by surgery is most relevant for localized grade 1 and grade 2 neuroendocrine tumors. It requires a mandatory, full preoperative assessment that includes relevant biochemical, conventional, and functional imaging. All cases should be discussed in a multidisciplinary team meeting with specialist surgeons to ensure careful patient selection, minimizing complications, and assessing both the primary tumor and any liver metastases for surgical removal. Peptide receptor radionuclide therapy, or PRRT, with lutetium-177 dotatate delivers targeted radiation directly to tumor cells. The landmark NETTER-1 trial showed dramatic benefit in small intestine NETs. Median progression-free survival wasn't reached in the PRRT group at 20 months, versus only 8.4 months with high-dose octreotide. That's a hazard ratio of 0.21, meaning PRRT reduced the risk of progression by 79%. The treatment involves 4 cycles given every 8 weeks, combined with kidney-protective amino acid infusions. Following peptide receptor radionuclide therapy in patients with somatostatin-positive tumors, the preferred strategy after somatostatin analog progression depends critically on tumor characteristics. For patients with strong, homogeneous somatostatin receptor expression and well-differentiated grade 1 or 2 tumors, PRRT is increasingly being considered earlier, sometimes even as second line after SSA progression. The earlier versus later debate centers on this: use PRRT while tumors are still highly receptor positive, or save it for when other options are exhausted. Current evidence leans toward earlier use in appropriate candidates. Everolimus, an mTOR inhibitor, enters the picture in specific scenarios. The RADIANT-4 trial showed benefit across gastrointestinal and lung NETs, with median progression-free survival of 11 months versus 3.9 months with placebo. Everolimus makes most sense when your tumor lacks or has insufficient somatostatin receptor expression, making somatostatin analogues and peptide receptor radionuclide therapy less effective. You have progressive grade 2 disease with Ki-67 above 10%, or you've already progressed through PRRT. The side effect profile includes mouth sores, high blood sugar, and pneumonitis requiring monitoring. Sunitinib, meanwhile, is approved specifically for pancreatic NETs based on the Phase 3 trial showing median progression-free survival of 11.4 months versus 5.5 months. The side effect profile differs. Everolimus commonly causes mouth sores, high blood sugar, and pneumonitis requiring monitoring, while Sunitinib brings fatigue, diarrhea, and hand-foot syndrome. Discussion of these toxicities with your oncologist helps determine which fits your life better. Chemotherapy typically doesn't lead the sequence in well-differentiated neuroendocrine tumors, but has crucial roles. For pancreatic neuroendocrine tumors, the combination of capecitabine and temozolomide, often called CAPTEM, showed 40% response rates in the E2211 trial for grade 1 to 2 tumors. Streptozotocin-based regimens have been used for nearly 50 years in functioning pancreatic neuroendocrine tumors. Chemotherapy moves up in the sequence when you have grade 2 tumors with higher Ki-67, rapid progression, or high tumor burden requiring tumor shrinkage rather than just stabilization. Somatostatin analogues can be useful for controlling hormone secretion. Peptide receptor radionuclide therapy uses targeted radiation to treat tumors. For small intestine nets, chemotherapy efficacy is limited, so it's typically reserved for later lines. The key insight: chemotherapy isn't saving the best for last, it's matching the treatment intensity to tumor biology. These decisions depend on how aggressive your particular tumor is behaving and what you need the treatment to accomplish, whether that's rapid shrinkage or gradual control. Liver-directed therapies, including ablation techniques like radiofrequency ablation, or arterial approaches like bland embolization, chemoembolization, and radioembolization, integrate throughout the sequence rather than replacing systemic therapy. For oligometastatic disease, percutaneous ablation can provide local control while you continue systemic therapy. For multifocal disease, transarterial approaches can reduce tumor burden. Studies show symptomatic response in 55 to 75% of patients. Timing matters. In patients with refractory carcinoid syndrome, despite optimal somatostatin analog doses, liver embolization can restore symptom control. The median time to needing new systemic therapy after focal progression treated with local regional therapy was 32 months in one series. That's nearly 3 years. This approach allows you to maintain your current systemic therapy while addressing specific problem areas in the liver. This week, document your tumor characteristics. Request copies of your pathology report showing grade and Ki-67 index, and your somatostatin receptor imaging results. These two pieces of information, proliferation rate and receptor status, drive 80% of sequencing decisions. Create a simple document listing: primary tumor location, grade, Ki-67 percentage, and receptor imaging intensity. Bring this to every appointment. Discuss with your doctor 5 essential questions. First, based on my Ki-67 and receptor imaging, what's the recommended first-line treatment and why? Second, if I start somatostatin analogues, when would we consider switching versus adding another treatment? SSA are drugs that can help stop tumors from creating hormones. Third, am I a peptide receptor radionuclide therapy candidate? And what's your thinking on timing after SSA progression or later? PRRT is a type of targeted radiation therapy. Fourth, do my liver metastases justify considering liver-directed therapy now, or should we wait? Fifth, how will we personalize this sequence if standard approaches don't control my disease? Seek urgent evaluation if you experience sudden worsening of hormonal symptoms not controlled by current therapy within 48 hours, suggesting carcinoid crisis. New severe abdominal pain, especially with prior liver embolization, possible liver abscess, high fever above 38.5 degrees Celsius with current treatment, potential infection, sudden confusion or altered mental status, or rapid weight loss exceeding 5% in 1 month. Carcinoid crisis can involve symptoms such as flushing, diarrhea, wheezing, and changes in blood pressure. If you are taking somatostatin analogues or SSA, these symptoms may be affected. Somatostatin analogues are medications that block hormone release. If you are taking peptide receptor radionuclide therapy, or PRRT, be aware of the listed risks. Peptide receptor radionuclide therapy is a type of radiation therapy. For treatment decisions, request multidisciplinary tumor board review when you're facing a second-line choice between peptide receptor radionuclide therapy and targeted therapy. Your tumor has mixed features, you're grade 3 well-differentiated, or you've progressed through standard sequences. Peptide receptor radionuclide therapy, or PRRT, is a type of radiation therapy. These complex situations benefit from multiple specialists reviewing your case together. Let me quickly recap. Most well-differentiated neuroendocrine tumor patients start with somatostatin analogues for growth control. Somatostatin analogues, or SSAs, are a type of medication. Then, sequence peptide receptor radionuclide therapy earlier rather than later, while receptors are strong. Peptide receptor radionuclide therapy, or PRRT, is a type of targeted radiation therapy. Integrate targeted therapy when receptor expression is low or after PRRT. Position chemotherapy based on grade and biology. Weave liver-directed treatments throughout for local control. Your next step: gather your pathology and imaging reports this week. This information is for education. Always discuss your individual situation with your healthcare provider.